good afternoon, y'all. My name is Dave Delauter. I am a therapist here, and Colette was kind enough to ask me to do a little bit of an in-service for you guys on BiPAP. One of the girls this morning said it was her least favorite thing. Well, hopefully I can dispel some of the problems that you all are having, and we can answer some questions and go through a couple of different things and get you a little bit more comfortable with it. Actually, it's a very, very simple machine. I'll talk about the machine a lot, but what I want to start out with is actually what BiPAP is, why we use it, and some different things along that line. BiPAP itself is kind of a misnomer. BiPAP is a trade name. So the correct terminology actually is non-invasive positive pressure ventilation. BiPAP is a trademark of Respironics, and it's just kind of because it was kind of the first one, we just use it all the time. So we say somebody's going on BiPAP instead of NPPV or NIPPV or however you want to say it like that. So it's a little bit of a misnomer, but nonetheless, that's still kind of the most popular one that's out there. However, numerous other companies have come up with the devices that are now out on the market as well. It's used in the acute care setting. It's also used in the home setting. It's used in the intermediate setting. We use it over at TCU. So it can be used everywhere. And just because you're on BiPAP doesn't necessarily mean you're going to need oxygen. You may just need it for obstructive sleep apnea. We use it for central sleep apnea. We use it for amyotrophic lateral sclerosis, some of the neuromuscular diseases. More acutely, we use it for CHF, respiratory failure, things along that line. And we hopefully get the patients turned around pretty quick. One of the neatest things that ever happened was when they discovered that, and I'll tell you guys like I told them this morning, if you've got a patient in CHF, don't call me to come and give them a breathing treatment because it's going to do absolutely nothing for them. They need Lasix and they need BiPAP, okay? And one of the greatest things that could have ever happened was when a group of physicians got together and did a study, and then they published it, I think it was in the mid-90s, about how the effects of BiPAP and these ER docs. We get some patients in, and I literally have had patients come in frothing pulmonary edema, CHF, and we've given them Lasix and BiPAP, and 4 or 5 hours later we're sending them home because they're doing okay. And it's really pretty cool that we can get them turned around that quick. That's what a patient needs when they're in CHF. They don't need a breathing treatment. They don't need bronchodilators. They need oxygen, they need BiPAP, and they need Lasix. And that, hopefully we can get them, with those three things, we can get them turned around pretty quick. So there's some of the diseases that we use for. With BiPAP, you have two pressures. You have an upper pressure or an inspiratory pressure, and you have a lower pressure or an expiratory pressure. And you'll see it say IPAP and EPAP. IPAP is inspiratory positive airway pressure. EPAP is expiratory positive airway pressure. You have a high set, so you have the high setting, say it's at 12, the low setting is at 6, and then in between that number is what we consider pressure support. So if you have a 12 and 6, the in-between number would be 6 of pressure support. And that's that little bit of a boost that the patient is getting, because what happens is when the patient takes a deep breath in, or takes a breath in, I shouldn't even say a deep breath, patient takes a breath in, excuse me, the machine gives them that 12 centimeters of water pressure, and it helps to increase their tidal volume, it helps to increase their functional residual capacity, helps to increase their oxygenation, and it helps to increase their ventilation, and it helps to decrease their work of breathing. When they exhale, they're exhaling against a positive pressure, that positive pressure of 6, and what happens then is it does all of the same things, and by doing the way it does it, it helps with, everybody knows with COPD or emphysema, the airways get real floppy, and they just collapse down. So when they take a breath in, they open up real nice and big, and when they exhale, they just shut down. That's where you get the air trapping, you get the barrel chest, you get the CO2 retention, all of those different things come along with it. What happens with BiPAP when they're exhaling against that positive pressure, they exhale and the airways don't collapse completely. So it helps get the carbon dioxide out, helps them ventilate better, gets more space available for, and recruits more space available for oxygen and ventilation when they take the next breath in. Okay, so that's how it works physiologically. The question about documentation arose. We check these things every 4 hours, and that's whether they come in and are on our machine or whether they bring one in from home. We check and make sure everything's working okay. We check their oxygen saturation. We document that the pressures that they're on. We document whether they're on our machine or whether they're on one that they bring from home. The ones that they bring from home, obviously, maintenance has to check them out, check the cords out, and just give it approval so they can plug it in and that there's no problem. and then after that's done, they can set it up. And most of the time, they need very, very little help to get it put on. If they do need help, we come up and give them a hand. And we know the patients that do need help and that don't need help, and we can come up and still work with it and give them a hand without any difficulty. So we do monitor every 4 hours. You want to watch out for the desats, obviously. You want to watch out and make sure. Now this machine, and I'll talk about it even. I'll tell you about it now, but we'll talk about it even a little bit more. The really nice thing about this machine is that it compensates for a leak up to a certain point. Now, if it's this humongous leak and the patient has the mask sitting kind of cockeyed on his face or he's ripped it off, obviously it's not going to compensate for that. But up to a certain point, the machine will compensate. So even if it's saying it has a leak of 25 to 27, 28, the patient is still getting the pressure, the desired pressure that it wants. Talking about the mask, hopefully, and you guys really, once we get the patient, we get the mask set up, you guys shouldn't have to worry about the mask other than to take it on and put it off. You don't have to worry about adjusting it. We're going to do the proper fit. We're going to do the proper adjustments when we put the patient on the mask. Now, the caveat to that is when I walk in and I see these Velcro straps all hanging all over every place, I have to go back and I have to start all over again after I've had that adjusted for the patient. It's very, very simple. You have 4 straps. These 2, don't touch them. Okay? Leave them where they are. These 2, once they're adjusted, all you have to do is take this, put your finger there, and just snap that right out. Most of the time, you only have to take one off, and it'll slip off the rest of the patient. Then when you want to put it back on, you just slip it down over the head and just, same thing here, just snap it right back into place. Okay? You shouldn't have to undo this Velcro or undo these straps at all. Once you guys get that patient, they're going to be adjusted and it's going to be ready to go. This machine goes on a standby mode. It does have an on-off switch. I'm not going to show it to you. All you have to worry about is the standby. When you push the standby, as you can see now, when you push the standby, it's going to beep at you, and it's going to go through about a 30 to 60 second test. Checks the alarms, checks the internal pressure, checks the circuit, all that fun stuff. Don't put it on the patient when it's going through this test because they're not going to be able to breathe. And now you got BiPAP. That's the high pressure. Now I'm simulating the patient, and I don't know how well you can see it, and I apologize, the folks on the film will not be able to see it. But there's a little thing down here that says trigger. And every time I leave off and make this thing think that I'm taking a breath, it says patient. Now what does that mean? That means that this is sensing that the patient is taking a breath, and it's giving the patient the pressure that it needs. Because remember, you have a pressure on inspiration, you have a pressure on expiration. I better say exhalation. Expiration probably doesn't sound very good, does it? The machine knows the difference. When it senses that the patient's taking a breath in, it gives that higher pressure. When it senses that the inhalation has cut off, it reverts to that lower pressure so that they're exhaling against a lower pressure and they're not getting a constant pressure back and forth. Now, this is saying patient trigger. This also has a rate. I can set a backup rate. We use backup rates predominantly in neuromuscular diseases such as Lou Gehrig's disease. What that does, or central apnea, what that does, it starts the breath for the patient and kind of reminds them to take a breath. Because with central sleep apnea, what happens is the brain just forgets to tell the body to breathe, and it just stops. And if something's not there to kind of remind it, we're not going to breathe and we're going to die. So that's with the central apnea, we use a backup rate, and it just kind of gives that little bit of a boost. Most of the time, 99% of the time, that's enough, and that patient starts to take a breath on his own. It senses it, the body senses it, and it takes a breath on its own. Lou Gehrig's disease, what it does is it helps for the patients to take a deeper breath, and it helps to decrease the work of breathing and allows them to sleep better and rest better, and if they stay on BiPAP, they've done some studies, if they stay on BiPAP 8 to 9 hours, they've shown that they have significant improvement in their ability to function for about 14 hours after that for patients in that type of a disease process. So BiPAP's a very, very good thing to have for some of these folks to have a little bit better quality of life. Unfortunately, there's no cure for it, but it does enhance their quality of life while they're here and while they're still doing well. If you look at the machine, on my right, your left, obviously, All this column, what this column is all the patient or all the settings that I'm putting into the machine for the patient. So this is the machine. This information on the left side is patient information. When you come in here and look, you'll see that I have an IPAP of 10, an EPAP of 5. That means when this patient takes a breath in, they're getting a pressure of 10 centimeters. When they exhale, they're exhaling against a pressure of 5 centimeters. So what's the pressure support? 5, right. Okay, the pressure support, remember, is that number in between there. All right, and that's that support that the patient's getting. So they're getting 5 centimeters of support with each breath that they take. Then they're exhaling against that 5 centimeters, which is holding their airways open. Coming farther down, my next setup is my rise time. What the rise time is the amount of time it takes for it to reach its peak flow. So if a patient's a little bit air hungry and they're struggling a little bit to get that breath in, we can increase the rise time, which means that they're going to get the flow faster, and it'll hopefully keep them from being quite as hungry and working quite as hard to get that breath in. Next down, you're going to see my rate. Here again, this is the set rate. I can't remember exactly what. Oh, and by the way, I brought this machine up. This is the Focus. This is the one you guys are going to probably see most of the time. We have 3. We have the Synchrony, the Vision, and the Focus. You may see the Synchrony. That's not quite as popular as this one is, but this is probably going to be the one that you see most of the time. The disadvantage to this is the Vision is the one we use in the emergency room and the intensive care unit. They're being kept strictly for those acute care settings. One of the biggest reasons is we can adjust the FiO2 in 5% increments with that. It's got a blender inside of it, and we can adjust it right there. This one does not have a blender in, and we have to titrate and put the oxygen in it. So if a patient's on 2 liters, we're going to put 2 liters into, and you'll most of the time see it hooked up to the mask at this little nipple adapter right here. That's one of the disadvantages. I kind of wish they would have done that with this. It would have made it a little bit easier to work with. But it's a good machine, and it works very, very well. So the rate is 10. So that means that this thing's going to start a breath 10 times per minute. Anything the patient does over and above that, same as on a ventilator, they're going to take the breath, and they're still going to get the pressures that this thing gives. But the machine's going to remind them of taking a breath 10 times a minute. With conscious, alert patients, just for a rate really doesn't have much of an effect. Most of the time you probably will not see a rate set on one of these things, or you may see it set at 4. 4 is the minimum that it goes. So you may see it, you may not, but just remember what that's for is it kind of gives it a little bit of a boost, and it kind of reminds them to breathe. Or sometimes we'll kind of override their rate or keep the machine going with them to make sure to try to blow off, in respiratory failure in particular, to try to blow off some more of that CO2 and see if we can get them turned around a little bit quicker and hopefully eventually get them off of this thing fairly fast. So we may override it, we may have it kind of set in that medium place, or you may see it set for a neuromuscular problem depending on what it is. Okay? Next down is the inspiratory time. This has an inspiratory time of 1 second, which means that it's going to take 1 second for this to reach its for inspiration. Then inspiration on this machine cuts off and it goes into exhalation. Okay, you can adjust that to wherever we can adjust that. I should say to wherever we need it. It can be up to 2 seconds. Most of the time, when you see an inspiratory time of 1 second, you always should have your expiratory time at least 2 times more than that. So if it's 1 second, it's going to be 2. 2 seconds is going to be 4 to 6. 3 seconds is going to be 6 to 7, 8, somewhere around like that. Your COPD patients, of course, you're going to see a longer expiratory time than you do with normal lungs and people who are on this for just like a sleep apnea or something along that line. Next 2 down, ramp time and start time, or in ramp start rather. The ramp time, we can put it into 45 minutes. The ramp start is the pressure that it drops down to, and what ramping is, and you guys probably will not see that in here. We don't use ramping here. That's more for a home use. What happens is we put a ramp on to help the patient get used to the pressure. So if I've got a patient on 12 to 14 centimeters of pressure, when I put that into his face, they're going to feel like it's going to take away their breath, and they're going to complain. That's one of the biggest complaints, that they can't breathe because of all that air blowing into their face. What happens if you hit that ramp, it drops down to wherever you have it set. So right now it's set at 4 centimeters. It would drop down to 4 centimeters of water pressure, and over the period of time that I have it set for, it would build up to, let's just say it's at 10, let's just say we'll keep it at 10, it would build up to that 10. So if it starts at 4 and I have it set at 30 minutes, over 30 minutes, it'll build up to that 10 centimeters water pressure. theory behind that is most patients, once they start getting used to it or have just that little bit of a flow, within 30 to 45 minutes, hopefully they're going to be asleep, and then they're not going to realize that that higher pressure is blowing into their face. And that's where the ramp came from. When I first started, I wear CPAP. When I first started wearing CPAP, I used a ramp. I don't use it anymore. And I wear 18 centimeters of water pressure. And it's just, I just put it on and it starts and you just go. But I did start using a ramp when I first started wearing CPAP. So it's a good device, but you probably won't see it on BiPAP in here. That's more of a home care thing for home care setting. Over here is your actual rate. Now this includes the 10 that the machine's giving plus, and it's kind of a little bit of the patient's taking all of these breaths. So that is an actual rate. Even though the machine's kind of reminding it, the patient's still taking his breath. So it's an actual spontaneous breathing rate. Because remember, this is not a ventilator. I can use this on a trach patient. I am not going to use this on a patient who's been intubated with an endotracheal tube. We can adapt it to use on a trach patient. They do adapt it to use on trach patients at home. But for an acutely ill patient, we're not going to use this with an endotracheal tube. They're going to be on a ventilator for that. Okay, so this is not a mechanical ventilator. Off-label, we can use it for some different things, but it's not recommended to use it as a mechanical ventilator. So you've got your actual rate, your estimated tidal volume, estimated minute volume, your leak. Now I've got a huge leak, but remember I told you that it can compensate up to a certain point. And again, if the patient has it turned to the side or pulled off, it's not going to compensate for that, and you have to readjust the mask. But it does compensate so that the patient does get the appropriate amount of pressure that you have set. The apnea, number of apneas, what this does is this tells me that this patient's had 48 apneas per hour, so it has an alarm setting in there. To be quite honest with you, edit this out. No, I'm kidding. We usually turn the apnea alarm off because it's one of those things that's kind of annoying. Now, if it's a critical patient, we keep it on there because we want to see it. But most of the time when they're going to come out here and work to you guys, they're going to be past that critical phase. They're going to be kind of on that transition phase, and you're not going to have to worry about the apneas quite as much. But this will tell you how many apneas it has. We do have an apnea alarm we can set up to 60 seconds. It goes 20, 30, 40, 50, and 60. Very important button, your alarm silence. Okay? Your alarm reset, you guys really don't have to worry about that one. The one you got to worry about is your alarm silence. This is the alarm reset. This will give you, as you saw when it first came on, this is a red flashing light, and it gives you a red flashing light and an audible alarm. Okay? If you can't figure out what's wrong, or if it's not the mask, don't be afraid to call us. I know sometimes we give you guys a hard time. I hope I don't. I try not to. But I know sometimes you guys feel like we give you a hard time. For that, I apologize. It is our job to come up here and to make sure that this thing is working properly. So if you guys run into a problem and you can't figure it out, don't be afraid to call us. Just don't let me walk in and find straps laying all over the place, okay, and the Velcro pulled out. Then I might huff at you a little bit. Stand by. Now remember, I told you I'm not going to show you the on-off switch because you don't need to know where it is. If you look hard enough, you'd find it, but you don't really need to know where it is. All you got to do is hit standby. That's the button down here in the corner. You're going to have a cue that it says want to power off. It's got cancel and OK. If you look over on this side, which we haven't talked a whole lot about, because you don't need to worry about this side except for this button, it's going to say up and down. Well, you can hit up and down. You can hit the same one, and it goes from side to side. And I don't know if you guys can see, it's flashing and highlighting. Now it's OK. Now it's cancel. You hit it to OK, and then you hit enter, and it shuts down. And that's all you have to do. Okay? Now remember, when you turn it back on, it's going to go through that about 30-second to a minute test, so you don't want to put it right back on the patient. You want to wait, let it go through the test. When you start hearing it crank up, then you can put it back on, put the mask back on the patient. Whatever settings you put it on standby on, it defaults. In fact, if you actually turn this machine off, it still stays on the same settings when you turn it back on and put it back off, take it back off of standby. There are two types of mask. This is the full face mask, and what this does is it fits over the nose and the mouth. It's got, if you can see here, and I haven't taken this off, but it's got a foam padding up here that crowns the forehead to make more patient comfort. Then you also have a nasal mask. Most of what we use here is the full face mask. You may see the nasal mask come in with patients who have it at home. So that's why I wanted to make you aware of it. Now somebody brought up about the nasal pillows and the nasal cannulas that they have for BiPAP. they've kind of fallen out of favor a little bit compared to what they were when they first came out. They thought they were the greatest thing since sliced bread. When they first came out, they could get these masks off of these people's faces and they could put these big, huge cannulas inside of their nose. Well, anybody that's worn just a plain nasal cannula knows how uncomfortable it is. These things are about this long and they fit inside of the nair. So just imagine how comfortable that is. I actually tried one when I first started my CPAP, and it's not all that comfortable. So you don't see them quite as much as they used to. They are still out there. So if you see this crazy looking cannula that's about yay long and the tips of it fit in it, they're about that long and about that big around that they go up inside of the nose, that's what it is. But you may not see it quite as much, particularly with BiPAP. That's more of a CPAP device. But you may see just the nasal mask, and all that does is it fits right over the nose. Same strap configuration. This one, however, doesn't have the little snaps, so you do have to take one of the Velcro and slide it off. Again, most of the time, all you have to do is loosen up the one, and that way all you have is one to put back on, and then just tighten it up and get it adjusted. When you tighten it up, you want to get it snug against their face. You don't want to have it smashed against their face. You just want to get it snug, because remember, this will compensate for a little bit of a leak. And you want the patient to be comfortable so that they keep it on and they wear it. Talking about the skin a little bit, talking about the pressure on the skin, you may see some breakdown. When I first started wearing mine, my nose broke down right here, and I got really red and really sore for about 2 months. And then finally I got, I don't know if it's a gristle or a callus or what exactly it is, it doesn't bother me anymore. Patients come in, you may see some breakdown, particularly on the bridge of the nose. What we can do, we can put Duoderm on the nose, or we can put Duoderm on the inside of the mask, whichever is most comfortable for the patient. Okay? Either way works just fine. Patients with nasogastric tubes, you can still put them on CPAP. It's a little more uncomfortable, and you're not going to see the nasal mask with that. With a nasogastric tube, you're definitely going to see the full face mask. It's a little bit uncomfortable, but this has an outer silicone seal, and what that does is it will seal down and around that nasogastric tube, so you still get the proper pressures and you don't get as much of a leak around it. You may get a little bit more of a leak with the nasogastric tube, but you're not going to get that much of a leak because it does seal down and around it. Okay? But if you do have some skin breakdown, put some Duoderm on it. Don't rub cream on their face because it's going to cause it to slide and you're not going to get a good seal. Okay? So you're going to want to use the Duoderm or some other type of a skin barrier that doesn't cause any kind of an oily reaction or any kind of a skin cause the skin to become slippery. Facial hair, yeah, you might. The mustaches are okay. Mustaches, particularly with full face mask, because it's not going to be. Most of the time with the nasal mask, it actually kind of runs right across here, so you're not going to have too much problem with the mustache. Beards can create a little bit of a problem, and you're going to probably have to pull it down a little bit tighter than you normally would think you'd have to. So you're going to have to, and again, by the time you folks get the patients, the mask should be adjusted properly for that patient if we did our job. Okay, so by the time you guys get them, all you have to do is worry about hitting that standby button, popping that one strap off and getting it off of them so they can eat. For lack of a better way of putting it, this is kind of at times a last resort rather than intubating them. Particularly with some of our COPD patients who occasionally come in CHF, we don't want to put them on a ventilator because we'll never get them off.
And some of them have requested not to.
And some of them have requested not to be. But we need to still do something. We need to keep them comfortable. That's where this comes in. So we can put them on this and hopefully get them turned around to a place where we don't have to put them on a ventilator. So this, in an emergent situation, this is the thing that can be considered prior to intubating a person, and hopefully we can get them turned around without having to intubate them. Well, some of the risks you can run into, you may have a pneumothorax. It's a slight chance, but you may have a pneumothorax, particularly with some of these fragile little old people that they might have a bleb down there, and even the slightest pressure is going to cause it to pop. That's about the biggest thing. Some patients panic, needless to say. That's a risk. It's more of a, maybe we shouldn't say that's a risk. That's more of a side effect, maybe would be a better term for that. But they will panic, and I will tell you, once you get them used to it, most patients, if they're sick enough to be put on this thing, they don't care. But if you got to get them calmed down, if they haven't had a van order and they can take it, give it to them and help them just take the edge off, and then we can get this thing on and get them turned down. Now, we can titrate this to work at the patient comfort. A lot of the docs will write a certain pressure I'll put it on, the patients will say, well, that's entirely too much. And what I'll do is I'll call the doc and see if I can fool around with it and get it to a place that's comfortable, more comfortable for the patient, but still doing what we want it to do. And they're pretty lenient with that, and we can kind of play with it and get it to a place where they want it. Biggest thing is pneumothorax. Patients may panic a little bit, get a little bit frustrated. Desaturation is a complication if they are off of it in a critical state, and if they need, if it needs to be used as a ventilator, or in obstructive sleep apnea. If they're on CPAP or BiPAP for obstructive sleep apnea, what that means is that somewhere along the line they're not breathing properly, and when you don't breathe, you don't get the oxygen, and your saturation drops. So if they're off of it and you see their saturation start dropping, or if you see their saturation start dropping, I should say, and you go in and check and they're off of it, that may be why. Because they may have an obstructive sleep apnea, and that might be why they're on the machine to begin with. Thank you guys very much. It's fun. Thank you. And don't hesitate to call or don't hesitate to ask questions. And if I don't know it, I'll find out for you.